Okay, good morning. It is hopefully our last installment of Chapter 17, our Cardiovascular Emergencies chapter. We've got quite a bit to cover, but we may be able to put this in one. If not, we'll break it up into two, but we're going to see what we can do here. So let's carry on. Management of acute coronary syndrome. So among patients with ACS, those with the STEMI are most likely to benefit from reperfusion therapy. Remember, the whole idea is that they have a block and it needs to be fixed one way or the other before more and more damage happens. So starting treatment at once on arrival at the scene for any patient with chest discomfort because the benefits are time sensitive. So as we've talked about, that time is muscle theory. It works here. So, and then even before you complete the history or secondary assessment, we need to start that treatment. So, you walk up and you make contact and you're able to look at them. The call was for chest pain. Their color looks like crap. They, they just look horrible. They have positive Levine signs, so they're, have that fist being clutched or clenched. And right away, as you're starting to question, you can say, hey, let's go ahead and get them on O2, get me a complete set of vitals. You can start moving ahead. So, you've got lots of things that we can do. I'm not moving. There we go. Place the patient at physical and emotional rest. So remember, stress is a big thing. Releases cortisol, which is hard on the body. Of course, all of the adrenaline that goes on. So that is one topic that has been debated over at least 20 years, because since I've been in EMS, is whether cardiac patients should be ran in code 3 or not. Because all we're doing is placing more and more stress on them. We're allowing all of this adrenaline and all the catecholamines and everything to surge through the body, and it's causing a lot greater workload on the heart. And if it's already a damaged vessel, the last thing we need to do is insist that the heart works harder. So the one thing we want to do is if we're able to, at least try to put them at ease. Sometimes it's really hard to, because we're usually business-oriented kind of folks. And want to get in and do what we need to do and worry about all that touchy-feely stuff later. But we do need to understand that just reassuring them that we're doing everything that we can and we're taking them to the right place and all those things, that will hopefully put them at ease. Because the last thing we need is for them to work harder with a damaged organ. So first thing we'll do, or not first, but begin treatment, place the patient in semifallers. Don't let them get up and walk on their own. If they're complaining of chest pain and appear to be having some kind of cardiac event, don't make them stand up and walk. If it's one thing to have them just stand up, you bring the cot to them. Don't make them walk across the room, because then you're going to probably work a different algorithm after that. I've seen it happen before that somebody was in VTAC, that the medic didn't know they were in VTAC, had them walk across the room. Well, we were lucky that the next thing we didn't do was work a full arrest. So record vital signs, get the blood pressure with these critical type patients if we believe it's a coronary event, cardiac event, every 5 minutes. Of course, we got to get the pulse rate. Put them on the monitor, listen for rhythm irregularities, keep the cardiac drugs close at hand, treat pulseless rhythms, tachycardia, symptomatic bradycardia. Follow all of our algorithms for that, or our local protocols. Of course, initiate CPR if needed. So the MONA mnemonic, it's not as applicable as it used to be, because MONA used to be the big deal: morphine, O2, nitro, and aspirin. Which is kind of funny because they have those. They have MONA here, but then they don't really put it here in the same way. But anyways, we're not using morphine like we used to. Now a lot of docs have moved on to fentanyl for cardiac reasons, for cardiac cases as well. It used to be primarily trauma, and now it's moved on to cardiac as well. And I think it's mostly due to it has a little bit more expected side effects. With morphine, it's kind of a crapshoot at times of what kind of maybe a decrease in preload and things like that a patient gets based upon their own way their body works, how they process it. So MONA morphine, O2, nitro, and aspirin. Those are the 4 things that we're going to work on. Patient is dyspneic, hypoxemic, or has obvious signs of heart failure. We're going to give them O2. And remember that number, that 94% or higher, that's the number that we're going to use as our benchmark. Of course, we're going to get a 12 lead. Now, the one thing I've probably said it on here, but don't delay treatment. Don't delay transport. Don't delay anything. If you believe that they're having an MI, that's fine to get a 12 lead, but don't. If you're able to do that within the constraints of your time, that's fine. But don't delay time getting them to the cath lab for that 12 lead when they look sick, their vital signs say they're sick, all of those things. You can get a 12 lead going down the road. It doesn't need to be perfect, but don't waste, all I'm trying to say is don't waste time focusing on this 12 lead. Treat your patient, not the monitor. So you want within about 10 minutes of patient contact, if you believe this is a cardiac event, we need to go ahead and get that 12 lead. Before perform the ECG before administration of any medication, especially aspirin and oxygen. Repeat the 12 lead with each set of vital signs. I always like to do it. Get your initial 12 lead, get at least one more, if nothing else, just right before you leave. So, as you're pulling into the ER drive, go ahead and hit you another 12 lead, and that way you can, if there was something evolving, the ER doc can take a look at it and see kind of how things, what happened. So if symptoms suggest ischemia or infarction, the 12 lead allows for rapid placement into one of 3 categories. So a STEMI, ST elevation in 2 or more contiguous leads, a non-ST elevated MI, and then normal. So remember that non-diagnostic. So when that a normal ECG doesn't rule out ischemia, injury, or infarction. All it says is that electrically we're not seeing damage. Doesn't mean that there's not damage, though. So it's just like cardiac enzymes. Many times, you can pull up cardiac enzymes and they look fine, but they're having an MI right then. So some of these things are a little bit weird. So once again, treat your patient, not your monitor. So when you look at somebody and you think they're having an MI, yeah, you're going to go ahead and do a 12 lead, and that's one more tool to confirm it. It doesn't rule it out saying, no, they're not having a 12 lead, as well as when you look at a 12 lead and it looks like there's elevation, you're not going to say they are having an MI if no other signs and symptoms are there. So it's just one little tool, just a small diagnostic tool for what you're trying to do. Now, hang on, give me a second here. I'm going to move over to my fancy-dancy TV screen. We'll talk about this 12 lead here. So, talking about 12 leads, we've already hang on, here we go. We've already talked about how we're going to read these, right? So, once again, all of lead 2, long continuous strip, and then we're going to, I'll just go ahead and mark it one more time, usually for you guys that hate it. You may already have figured something else out the way you want to do it different, and that's okay. But I'm going to mark this one up. So, all right, Lisa. So, first thing we're going to do is let's go ahead and look at our continuous lead. So we have lead 2. Let's see. We got some P waves. Rate is what? Looks like we got a rate of about 3, 150, 175, 6, somewhere around 60. I don't know, maybe in the 50s. Rhythm looks to be pretty regular. P waves, looks like there's P waves. They're upright and present. PR interval looks pretty normal. 1, 2, 3, 4, 5, somewhere around there, right around the maximum limit, I would say, for the most part. QRS looks pretty normal. It looks like it's, 0.08 or something. So I would call this sinus rhythm, but just looking at the rhythm by itself, sinus rhythm. Now, of course, we did notice this, right? So at our J point, we notice that we have what appears to be elevation. That's in lead 2. So let's talk about what we're going to do. Let's go ahead and look at this guy. So if we look at lead 1, we're going to start with our lateral leads, and we notice we have some depression, right? We notice even more depression here. 5 and 6 looks pretty normal. Go to 2, 3, and AVF are inferior. Looks like we have some elevation. 3 looks really ugly, doesn't it? Septal, that looks like it's not enough, but there's just a little bit of elevation, but not enough to go with anything. So, looks like we have some elevation. We also have depression in 1 and AVL. Go ahead and remember, or nothing else, call back onto your, I don't remember what page it's on, but what the leads you're using, or your facing leads, and then your reciprocal leads. You'll remember that 2, 3, and AVF, its reciprocal leads are 1 and AVL. So we see elevation here, and we see depression here. So not only do we have elevation in 2 or more contiguous leads, we also have depression in the reciprocal leads, right? So that's a really big sign that we got something going on. So that's kind of what we're looking at when we look at that guy, and it looks like this person, if they are, you would expect, by looking at this 12 lead, I would personally expect that they're probably sick, that they're having some chest pain and all of that stuff, because it looks like they have something going on. Everybody good? All right. Moving on. Get back to my notes here. So STEMI requires reperfusion therapy by one of the following. Percutaneous coronary intervention, or so basically the cath lab, or fibrinolytic medication to dissolve those blood clots. So you either get thrombolytics or they go to the cath lab, one of the two. Hang on, man, mouth's already dry. One of the things is you need to make sure that you know who has what. And it's good if you have the ability within your protocols just to go kind of wherever you want. I know some of you guys do not have that option, that you'll go kind of where you're told, that you have to go to one particular hospital, and then they'll figure it out from there. But if you were able to go somewhere else, so say you're down in, I don't know, say you're down in Purcell, and you had what appears to be a STEMI, it'd be nice, if you were able to fax a 12 lead, shoot the 12 lead in to Norman, ask them what they see and what they're going on, and they might say, yeah, go ahead and bring them here to the cath lab, or they might say, go ahead and take them to your local hospital and let's get some thrombolytics going, and then we can transfer them up here or whatever. So it's nice to be able to have some options. But once again, we always go back to our local protocols, don't we? Whether they're good or bad. If they're not good, then what you have is the responsibility to get into a place where you can make them better. So patients with STEMI, it's critical to minimize the time to treatment. So you have the door EMS to balloon time. So that starts at the first moment of the patient contact by EMS providers and ends when definitive therapy occurs. So when they get get to the cath lab and do the procedure, and that's what we're talking about. Door to balloon time, the interval between patient presentation to the medical facility and definitive therapy. Or door to needle begins when the patient arrives at the ED and ends with fibrinolytic medication is administered. So once they get thrombolytics. So this represents a time lapse before the patient receives definitive reperfusion therapy. So, say it's 54 minutes or whatever. They have some benchmarks that they want to hit that they understand is best. So the ideal STEMI system should include a couple of different things. Well-established protocols, definitely comprehensive training for us to be able to recognize this and know, to take who, where, and all of that. Some places are still using thrombolytic checklists. So, you're able to save a little bit of time by asking some questions and filling out a checklist. 12 lead, and then obviously having everybody experienced in some of the old ACLS. That's going to be pretty important as well. Provide pain relief. So administer nitro if you're sure there are no contraindications to its use. So once again, review nitro. Ensure that the patient does not have an initial systolic less than 90 We're not going to be given nitro to somebody that has less than 90. Also avoid administering nitro if right ventricular infarction is suspected. We've talked about that. Remember, you're just going to move V4 over onto V4R. If you have one of the monitors, I can't remember if it's 15s or what, I'm not sure with the new monitors, but there's one that has where you automatically put it on and it just shoots the V4R for you as well. But remember, with the right ventricular infarction, the whole thought behind that is that hypotension can result when preload is reduced, and that's what we're doing by giving nitro, right, is we're reducing preload. So that's the thought. Now, I think I mentioned this yesterday, but there is evidence and studies that are suggesting this is not quite such a strong reaction as we've once believed. But I believe all of our protocols are still probably going to follow that for quite some time, if not forever. Do not administer nitrates if the patient has used, I think they're called, what are they called? PDI, phosphodiesterase inhibitors. So we're talking about Viagra, Cialis, all of that stuff. Viagra in the last 24 hours, and then Cialis or Levitra, that's in the last 48 hours. Go ahead and give nitro sublingually as a metered dose spray, or sometimes people are still carrying the tabs every 3 to 5 minutes, and then typically that's up to 3 doses. That's for a stable patient. There will be times, and depending upon your protocols and your medical director, to where you may give a lot more. Back in the day before we had CPAP, one of my docs I spoke with at length about CHF patients because I kept seeming to have a bad run of them. It was pretty much, he gave me the go ahead just to give them as many nitros as I could get down them their blood pressure could tolerate, because, we're just doing so much with it. So it's doing so much work. So if you work at a place that you have that, then that's fine. If not, you give your 3, make sure you call your doc to find out about any more. So if the patient discomfort persists and his or her vital signs remain stable, then you can look at considering some morphine or some fentanyl, depending upon what you give. History and secondary assessment. So obtain more details about the current symptoms, get you more details, more information, all of that stuff. Don't remain at the scene once you've taken the necessary precautions to stabilize the patient. So once you have your primary assessment and your, what we might say, life-saving interventions done, move on. Go ahead and get the rest of the stuff en route. We're wasting time sitting around while they're having an MI, and we want to find out what medicine they take for the gout or whatever else. Transfer the patient. Transport the patient. Once the patient is stable, transport to semi-Fowler position. So ensure the patient is comfortable as possible. Additional treatment may be advisable, especially for long transport. You may need to do something pain-wise or even medication-wise. Dysrhythmias are common the first few hours of an infarction. So if they're having one, or maybe you're taking someone after they've been reperfused, after they've given thrombolytics. I can remember one in particular case to where we took them after they had been given thrombolytics and broke the clot up, and their heart was throwing off all kinds of wacky rhythms. Thinking like 1 6-second strip, I saw 3 separate rhythms because the heart is so irritable and it's it's really wacky and doing all these things. So just be advised that you can see some different things. So a person with chest discomfort who refuses care is a high-risk refusal. So number 1, I always like to get the doc on the phone and let the doc talk to him. And then you need to do a really good job of documentation. So you need to make sure, the way that I always do it is I even tell the patient, up to and including death, that, there is a chance that it appears that you're having a heart attack. There is a very good chance that you are not going to survive this without going to the ER. And then I document that as much. I'll get pretty rough, and I would rather be complained on because I said they might die and they didn't because they went, rather than leave them there and they do die. So heart failure occurs when the heart cannot pump fast or powerfully enough to empty its chambers. So, what happens, you get the blood, it backs up into the systemic circuit, or even the pulmonary circuit. You can have both. It's a total heart failure. But it's a syndrome, not a disease. It's caused by several disorders that impair the ability of the ventricles to fill or eject with blood. So it's identified based upon the symptom onset, acute versus chronic. So, obviously acute means that it happens suddenly, and then chronic is a lot more slower. So the ventricle initially involved, whether we're talking about the left ventricle or we're talking about the right, that's kind of what we need to be thinking about. Although failure of either ventricle can occur by itself, they often occur together. So often right ventricular failure is a result of left ventricular failure. And when one fails, we're causing a lot more back pressure upon the other and causing the other ventricle to work so much harder. So you just get a lot of stuff going on. Once again, you'll need to remember your cardiac output equation. So stroke volume times heart rate, pretty easy, pretty obvious. 3 factors that affect it: preload, afterload, and cardiac contractility. So you will need to refresh yourself. There's still several people that have not quite got down preload and afterload. So I will ask you to go ahead and review that again, because hint, hint, you are going to see that. So heart failure can be caused by any condition that affects preload, afterload, contractility, heart rate. So essentially what we're saying is heart failure can be caused by anything that affects our cardiac output, right? That's what heart failure can be caused by. So if it affects the strength of the contraction, if it affects the rate itself, or how much blood is being pushed out, or how much blood is being returned, then that's what we're talking about with heart failure. Now, returning back to something we've already talked about, Starling's law. As you can imagine, you'll probably see that again. Remember, that's that stretch, talking about the stretch that these fibers can stretch. The greater the stretch, the greater the contraction. Of course, it's up to a certain limit, but the stretching allows the heart to eject more forcefully, so that's obviously what we're wanting. So you have an increased cardiac output for that. 2 types of left ventricular failure. You have systolic and you have diastolic. So systolic is when the left ventricle doesn't contract normally and has trouble pumping out all of the blood to the body. And then diastolic is it contracts normally, but it has become stiff, impeding its ability to relax and fill with blood between each contraction of the heart. And there's a number of things that can be the causes of this. Faulty heart valves, of course an MI, that's going to be the big one. Cardiomyopathy. Many times after someone has an MI, they start to have failure. So if that's something to keep in mind when you're running a heart failure case, if they don't have a history of heart failure and they don't have a history of CHF and they're not taking the meds for it, you should be kind of suspicious that maybe they had just had an MI. So make sure you're paying good attention to that. So within left ventricular failure, so the pathophysiology behind that, the left ventricle is most commonly damaged. See, what happens is the right side continues to pump normally, and then the left side, it can't keep up, and the pressure increases. So the left atrium swells because it can't empty the blood, and stretching of the muscle fibers can certainly cause some dysrhythmias. What happens, the pulmonary veins cannot empty the blood from the pulmonary arteries into the left atrium because it's already full because of that backup. So pressure within the pulmonary vessels increase. And then here's where it all comes down to that CHF stuff, is fluid is forced out of the pulmonary capillaries into the alveoli, essentially creating pulmonary edema, right? And obviously, we understand how all these things work, diffusion and everything else works. And we're not going to be able to make that oxygen transfer across a bunch of fluid. We need to have nice cleaned up and in shape alveoli so it can make that transfer that it needs to. All right, give me a second. All right, left ventricular failure. So pathophysiology, as you can see in this little diagram, you have kind of all the different steps that go into left ventricular failure. Excuse me. So, buildup of fluid widens the gap between the membrane, and then oxygenation essentially becomes impaired. So you see you have high pressure in pulmonary capillaries, that's the end, impaired gas exchange, possible cyanosis, as you just as you just scan all the way through here, you start seeing all the different things. So decreased cardiac output, decreased perfusion to kidneys. You have some renin-angiotensin-aldosterone system activated, which then causes sodium and water retention. And you just have this process that happens. Within right ventricular failure, you have some of the same things. And to eject the blood, the right ventricle must overcome the high pressure and congestion within the pulmonary vessels. So we've talked about that. If you have some ventricular failure, that the ventricle is unable to overcome that pressure, that afterload, then you're not going to get much stuff happening. The heart is just going to keep working harder and harder and not really getting much done. So it's only making things worse. So right ventricular failure. Another second here. Yeah. Can't keep up with the increased workload, right ventricle fails. So blood backs up behind the right ventricle, raising pressure in the right atrium. So if the right atrium is unable to eject the blood within its walls, then the blood backs up into the superior and inferior vena cava. And then, of course, the veins become congested with blood, and because the venous return is delayed, organs become congested. Rising pressure within the veins force serous fluid through capillary walls and into body tissues, producing edema. So that's where you start seeing pedal edema and that kind of stuff, as well as ascites. So peripheral edema is most apparent with feet and ankles. And as right ventricular failure progresses, generalized edema of the entire body may occur. That's anasarca. So cor pulmonale, right ventricular failure may occur by itself, meaning without left ventricular in conditions such as right ventricular infarction or a PE or pulmonary hypertension. So cor pulmonale is right ventricular failure caused by pulmonary disease. So usually the result of COPD. So pulmonary hypertension, that's a disorder in which the pressure in the pulmonary arteries is higher than normal. So, as we've kind of talked, the right ventricle must work hard to overcome that increased resistance, and then it eventually fails. Compensatory mechanisms. So a lot of this is what we've seen and what we know happens within the body is based upon compensatory mechanisms. So these mechanisms manipulate preload, afterload, contractility, heart rate, all to improve cardiac output. So if your stroke volume is decreasing so it maintains the same cardiac output, the heart rate may get kicked up, or vice versa. So within the sympathetic nervous system, boost heart rate, increases the force of contraction, constricts blood vessels. So you get a lot of different things going on, and one helps out the other. So accelerated heart rate and stronger force of contraction. Within that, you get increases the heart oxygen demand, reduces the amount of time the ventricles have to fill, and then also decreases the time for coronary artery perfusion when we talk about that accelerated heart rate. Decreased blood flow to the kidneys stimulates the angiotensin-aldosterone system. So the heart has to work even harder to pump against the high pressure. And then the aldosterone encourages sodium water retention, increased blood volume. Remember, it's holding on to that because it's recognizing that there's not enough fluid in there. And water, of course, is attractive or travels to sodium. So that's why the body is holding on to that. So these mechanisms, they increase cardiac output for a time, but eventually heart failure advances. So sodium and water enlarge the heart chambers, the ventricle walls thicken, the force of contraction decreases, and the heart is unable to handle the increased volume of fluid, and cardiac output decreases. So heart failure, when we talk about assessment, some of the things we can expect: sudden shortness of breath, even during rest, trouble sleeping. So they start to have nocturnal orthopnea. So they have to sleep basically with their head up a lot of times. Trouble sleeping, feeling tired or weak, nauseous, loss of appetite, JVD. So you got a lot of things that should make sense as to what's going on. but the likelihood of cardiac in origin is greater if the patient has a history of heart attack, high blood pressure, cardiovascular conditions. And then what can happen when we talk about sleeping is the patient may report having had trouble sleeping. So, because what's happening is that fluid pools in the lungs, essentially just drowning the patient in their own fluids. And then the patients often report feeling tired or weak. Patient may report having trouble concentrating, potentially could have been hypoxic. Restless anxiety, unexplained confusion, once again, could be hypoxia. So a lot of different stuff. It all probably makes sense. Now, a lot of times what the big confusion is, not confusion, but where people kind of get off, make some mistakes here, is it'll be like pulmonary, it'll be congestive heart failure versus pneumonia, because many times they sound kind of the same and maybe they present kind of the same, but we've got to think about a few of the mechanisms of how these two things work. So essentially, heart failure, the big difference should be that it's an acute onset, right? It shouldn't be a chronic onset like it's been getting worse over the last few days. Typically, there's an acute onset. Also, pneumonia patients should be febrile, whereas CHF patients aren't. So typically, if you're running a patient that is from the nursing home and they're kind of bedridden and have a fever, and you're wondering pneumonia versus CHF, to me, it's pneumonia until proven otherwise. And that's, for some reason, that seems to get us, especially as we're brand new, I think because we just overthink things. Assessment, signs and symptoms. So we see all these different things, possible diagnoses, differential diagnosis of heart failure. So, just these could be just other things that's going on. So cardiogenic pulmonary edema, cardiogenic shock, MI, ARDS, asthma, a lot of different things. Management, to decrease the work of breathing. So typically we're probably going to get them on some CPAP right away if they've got fluid on their lungs, right, to get some stuff out of there. When that long ago, before we had CPAP, when they were getting tons of nitros and Lasix and all that kind of stuff. And now CPAP has just revolutionized everything for us. Just blows those, cleans the alveoli out, allows everything to work properly. You do have to be careful when you take them off of CPAP. So you can get a flash edema, and it just occurs. I don't really remember why it happens, but it can certainly happen as you take somebody off CPAP. They can just fill up pretty quick. Another thing we want to do, decrease the work of breathing, maintain adequate oxygenation and perfusion, and then, of course, support efforts to decrease the workload of the heart. Now, remember, these patients are probably a little bit air hungry, and they tend to be quite anxious whenever they have this going on. So it may be kind of hard to get somebody on CPAP. What you've got to do is just get them, once they take a couple of deep breaths on it and they feel it take over and allow them to breathe even better, they'll usually be good to go with it. But sometimes that's not the case. So management, place the patient in position of comfort. Typically it's going to be, head up. Sometimes they may want to swing their legs off the cot, and you've got to fight somebody that they're so anxious and, they're just sick and they have this feeling of impending doom. So, we got to kind of be a little bit sympathetic and understand, but still have to maintain safety. We want to encourage it. So by having them sit, not when we're transporting, but sit with their feet dangling off, that allows some venous pooling in the legs, which reduces the venous return to the heart, and it also decreases the work of breathing. So put on the pulse ox on them, make sure we're at 94% or higher. Use non-invasive positive pressure ventilation to manage pulmonary edema. So what we were just talking about. Improves oxygenation and perfusion by reducing the work of breathing. Maintains alveolar inflation. Improves pulmonary compliance, slows respiratory rate, decreasing the work of breathing. And it does a couple other things. It helps us facilitate the delivery of bronchodilators. Obviously, if you remember about CPAP, that it reduces preload and afterload. So essentially that's going to be improving cardiac output, decreases the work of breathing, all of that stuff. So now we don't want to use this. Compromised airway, risk of aspiration. So if somebody's about to throw up or something, altered mental status, you don't. Blood pressure less than 90 because of that reducing preload. It doesn't sound like a good idea, does it? And then monitor the patient's respiratory status using waveform capnography. So at least get them on pulse ox if you don't have waveform capnography. Place them on a cardiac monitor, get you a 12 lead if you can. This is going to be a hard time, probably get you a good 12 lead because these guys are usually working so hard and shaking and everything else that you may not be able to get a very good 12 lead, and that's okay. Make sure you click your 12 lead button on your protocol to get it knocked out, but don't focus on that. It's probably not going to be a very good 12 lead anyways. So if your local protocol requires you to use a IV bag, then infuse fluid at a TKO rate, so basically about 30 mils an hour. Usually people just like to use a HEP lock or a saline lock. One thing that I like to do is especially for someone like this where fluid makes a difference, if you hang a bag and say you hang 500 mil bag, then at the end, when I get to the ER, I like to document how much was left to count, or I'll document it as LTC. So your bag was 500 and you gave 100. So you have 400 mils. So I would put 400 mils LTC, or left to count. And that just shows that, you didn't have a runaway IV. In the event that someone neglects their IV in the ER or whatever, it's just going to be a lot harder for someone to kind of pin on you that you gave this person a whole buttload of fluid when that was the last thing that they needed because they've already got fluid overload. So just something to think about. Sublingual nitro, it can be given to reduce preload and afterload, so thereby supporting cardiac output. And Lasix, so review your Lasix. That's a diuretic. Not currently recommended for use in treating heart failure, but it is something that has been used in the past. So moving on to management, surgically implanted ventricular assistance devices. So VADs may be used in patients who have heart failure. These things act as an artificial ventricle. So you have LVADs and RVADs and BiVADs. So doesn't depend on these things don't depend upon the contractility or electrical conduction of the heart. They just go ahead and work as the ventricle themselves. So the ones I don't know that I've ever taken care of an RVAD, I know that I have LVAD several times, and that's the most common one. So, it can be used in several situations. So it allows the heart to rest until the patient's heart can resume its pumping function. The times I've taken care of people, these were used as a bridge to heart transplants. And it can even be lifetime therapy. It's something that people are just on. Tamponade. Let me get a drink here. Tamponade occurs when the buildup of pericardial fluid compresses the heart. So the pressure within the pericardium increases as pericardial fluid builds up, and then the volume of blood or fluid in the pericardial space necessary to impair the heart's ability to fill depends upon the rate at which the buildup or fluid or of blood or fluid occurs, and then the ability of the pericardium to stretch to accommodate the expanded fluid volume. So, number one, you're not able to get either enough blood in there, there's just too much, or the ability to stretch and accommodate the expanded volume. So, everything's being compressed in there. Cardiac tamponade occurs when the buildup of pericardial fluid compresses the heart, impairing contraction and restricting ventricular filling. So it can develop in a couple of ways. Gradually, if caused by an infection or tumor, or rapidly when caused by heart surgery, pacemaker, central venous insertion, cardiac trauma such as a stab wound or a gunshot wound. Signs and symptoms include Beck's triad. Does everybody remember Beck's triad? Remember we've had a number of different things here that we talk about. We've got Cushing's triad, which we'll be talking about, head injury stuff. We've got Beck's triad. You also, and the name escapes me, but when we're looking at pneumo, heck, I may just make it up. There's may not even be. I know that we have those three differentiating factors, but the big difference between when we look at tamponade versus pneumo, which sometimes is a thing that will mess with somebody, is tamponade we're going to have muffled heart tones, whereas within pneumothorax we're going to have absent lung sounds, right, or diminished at least. Patient usually too ill to give his or her medical history when we're talking about cardiac tamponade. So the symptoms we typically expect: anxiety and restlessness, shortness of breath, chest tightness, dizziness. All of this is based upon the heart trying to work and it's not working right. And so you have impending doom stuff. You have adrenaline being dumped into the system to make things work better. And that's just a lot of stuff going on. So suspect cardiac tamponade in any patient with a penetrating wound of the chest or upper abdomen. So a couple of things we just talked about. Differentiate between tamponade and a pneumo. In tamponade, the lungs aren't affected. So you expect the breath sounds to be equal. You expect trachea to be midline. But within tamponade, you have a couple of different things. So you have JVD, which we can have with the pneumo. We have hypotension, once again, but we have muffled heart tones versus absent breath sounds. So now remember, muffled heart tones, that is not a telltale sign of Beck's triad, meaning it's not something that you have to have before you suspect that it's a tamponade. These signs are actually present in fewer than half of all the patients. So you may or may not hear muffled heart sounds because maybe you can't even hear the heart sounds very well, or maybe you're not very good at listening. A lot of different things. So if you suspect that they have a cardiac tamponade, in my opinion, you treat them as such, and you get them moving, and you get them to the local trauma center, and you get them help. But some of the other signs of cardiac tamponade: colon pale, mottled, cyanotic skin, tachycardia, weaker absent pulses, narrowing pulse pressure, which is an early sign, pulsus paradoxus, which is a late sign, signs and symptoms mimicking heart failure. When it develops slowly, look for dyspnea, orthopnea, JVD. And then a pericardiocentesis is what's going to have to be done for this. Now, we are not going to do that. There was a time when that was a paramedic skill, at least in certain portions of the country. But as you can see, as on this slide says, as little as 50 mils may cause improvement. So, this is not that's how fragile this whole system really is as to working properly. So if trauma is a source of the patient's signs and symptoms, first thing we need to address any life-threatening hemorrhage, ensure adequate oxygenation and ventilation, make sure that we're maintaining a pulse ox of 94 or higher, monitor IV, make sure you're following your protocols. If the patient has no signs of heart failure, then an IV challenge of normal saline would be good. And then we know that the pericardiocentesis is the ultimate treatment to withdraw that fluid. So if you're unaware of what that is, a needle is inserted into the pericardial sac and it drains or aspirates the excess fluid. Pretty gnarly. Cardiogenic shock. Moving on. Let's see where we're at, guys. We're going to get this done on this video. Good news. You're not going to have 14 more videos. Cardiogenic shock. Pathophysiology. So occurs if myocardial contractility has diminished. So we're talking about the contraction itself. Sometimes it can occur after a prolonged surgery or even cardiac arrest. So if cardiac arrest, ventricular wall rupture also. Symptoms: difficulty breathing, pale mottled skin, cool and moist extremities. So think about all the things that we've talked about with shock when we were in trauma earlier, and now we have just another version, which is cardiogenic shock. So when we talk about assessment of cardiogenic shock, family members are present. We want to ask whether the patient has a history of heart disease. If the patient's history might often include cardiomyopathy, congenital heart disease, maybe a recent MI, and that's a big thing, is these recent MIs can have all kinds of problems, heart failure and shock and everything else. So compensated cardiogenic shock, the patient may experience the following symptoms: restlessness, there we go, agitation, confusion, crackles, JVD, weak and rapid peripheral pulses, pale mottled skin, a lot of the things that we expected to see, right, when we talked about compensated versus decompensated, altered mental status, rapid and shallow breaths, pulmonary congestion, absent pulses, weak and rapid central pulses, pale mottled skin. So as you can expect, as ventricular function worsens, cardiac output falls, the systolic blood pressure progressively decreases, which is bad. We don't want that to happen if possible. So how we're going to manage this is we want to strengthen the contractility without increasing the heart rate. So after preload and afterload, and alter preload and afterload, and control any dysrhythmias. So we want to apply pulse ox, give them some O2, sitting position with the feet dangling. Place them on a monitor, 12 lead, of course. IV fluids if you're able to. Make sure the lungs are clear. This is all of these times that we've been talking about. Once you give, like, say, a couple hundred mils, say 250, you give 250 mils, stop and listen to lung sounds. Don't just blast in a whole liter of fluid, and next thing you know, half of it's into their lungs, because that's not going to work out very good for any of us. So go ahead and give some fluid, and then determine whether they have fluid on their lungs or not. So you see here, rapidly infuse 100 to 200 mils, and closely monitor mental status, breath sounds, pulse, blood pressure, all of that kind of stuff. So we want to withhold fluids. When do we do that? The patient's condition deteriorates or crackles develop. So if we start to notice that fluid is shifting into their lungs, then we definitely want to discontinue our fluid challenges. And then we get into some drugs. This is a good time to talk about this. As you know, you're going to need to know these really well. So within dopamine, you're going to need to know your dosage ranges. Norepi and epi, know your doses, know how they work. Within dopamine, know what your renal and mesenteric dose is, know what your beta response is, know what your pure alpha response is, at the dosage range. Whether it's milligram per kilogram, whether it's microgram, whether it's microgram per minute, all of those fancy things and how they all work. So right away, we know that they're vasopressors, so that's kind of should be a help us out there on, just kind of determining what they do. But now's a good time to talk about that. So make sure that you are prepared to talk about that. You'll need to know this stuff in lab, because many times you'll be asked that. So I would like to hang a dopamine drip. Okay, tell me about that. Well, what do you want me to tell? Tell me everything. Tell me how it works. Tell me the dosage ranges. Tell me this. Tell me that. So make sure you're squared away, because it can get awkward and uncomfortable in lab when you're unable to answer that. Especially if, like, say you took the test and you did really well, like you just crushed all of that information on the test, but then when we come to real life, you're unable to, recite it, or you haven't learned it yet. That's going to be even worse, because then it just kind of throws some questions out there. So if you're instructed to give a vasoactive medication, a couple different things we need to do. Check the IV site often, and then look at the patient's response. As with any medication, we want to document and assess the patient's response. So they had pain 10 of 10. After I gave them this, they had pain rated at 2 of 10. or I gave them this medication, their blood pressure went up to this. Those type of things. So, treat any dysrhythmias that are contributing to shock, emotional support. Except for correcting a life-threatening dysrhythmia, there are no measures you can take in the field to stabilize a patient in cardiogenic shock. What happened? How did that happen? Oh, I thought maybe I hadn't clicked on that yet. I'm sorry. Hypertensive emergencies. Moving on to high blood pressures. Hypertension is a diastolic pressure exceeding 90 milligrams of mercury. Persistent elevation of diastolic pressure is indicative of hypertensive disease, which can significantly shorten the lifespan and then predispose to other medical conditions. We learned when we talked about our chamber sizes that by having left ventricular hypertrophy, we see certain things on the monitor that's caused secondary to high blood pressure because the heart's having to work harder. And just like when you go to the gym and you rep out the bench, you're building that muscle. That's the same thing that heart muscle is doing. So you can have some real issues there. So some of these things you can have, talking about medical conditions, stroke and heart attack, heart failure, kidney failure from high blood pressure. Kidney failure, people have a lot of kidney issues when they've had high blood pressure for quite some time, particularly untreated high blood pressure. So most of these cases, they result from advanced atherosclerosis or arteriosclerosis. So the high afterload on the heart expands the filling volume, and then that Starling reflex is stimulated. So that raises the pressure, which the blood is injected from the heart. Blood pressure, so when we talk about numbers, blood pressure at rest is greater than 140/90. That's what is being called hypertension. So now, a single reading does not constitute hypertension. So, it's got to be several times, as well as like at rest. Not just, you got wound up, or like what happens with me, I'll drink too much coffee or pre-workout. Next thing you know, I'm all jacked up with right blood pressure's about to pop the top of my head off or something. So, we're not talking about in specific situations. We're talking about consistently throughout time. Persistent elevation of diastolic is indicative of hypertensive disease, which can, once again, significantly shorten the lifespan and predispose you to other things, so renal damage, stroke, heart failure. So hypertensive emergencies require rapidly lowering of blood pressure to prevent or limit organ damage. So malignant hypertension, that occurs when there's a rapid rise in blood pressure causing acute and progressive damage to organs such as the heart, brain, and kidneys. So the increase in blood pressure damages those blood vessels because, as we've seen in several other traumatic situations and just throughout medical cases, when you have that high pressure, all the little capillaries, some of these vessels will just burst. They're not capable of taking on these high pressures like that. So these vessels become inflamed and they can leak. And then if untreated, malignant hypertension can cause acute renal failure, MI, stroke, all kinds of stuff. So the determining factor for hypertensive encephalopathy, that's usually the mean arterial pressure. If you remember what that is, you have diastolic plus 1/3 of the systolic minus diastolic, which, if I remember correctly, is the pulse pressure. So when your MAP exceeds 150, fluid leaks out through the blood-brain barrier, causing increased intracranial pressure. So you can see there's just a lot of issues here. First noticeable signs, severe headache, nausea, vomiting, and then those symptoms are followed by seizures, mental status alterations, focal neurological signs, and if untreated, people die. And you don't want to die. So we gotta power through this, man. So assessment symptoms include, I think we took, headache, blurred vision, dizziness, ringing in the ears or tinnitus, dyspnea, chest pain, nosebleed, all of those kinds of things. So signs of a hypertensive emergency include a sick appearance. So when you look at sick versus not sick, they look sick. Mental status, that could be anything from responsive to altered or unresponsive. Pale flushed skin, or even normal skin that feels dry or warm or moist. But we have strong bounding peripheral pulses, high diastolic, usually higher than 130, possible seizures, signs of heart failure. So what's that? Could be crackles in the lungs. It could be some edema that we see throughout the body. Signs that are consistent with an MI as well. And then you might even see some ischemic changes in the 12 lead. Management. What are we going to do for these folks? Well, so provide supportive care. So we're going to give them some O2 if they need it. We're going to give us an IV. We're not going to delay transport. If it's unavoidable, we may need to initiate some drug therapy in the field. So labetalol decreases overall peripheral vascular resistance and prevents reflex tachycardia. So that's something you're going to need to pay attention to. And what that is, that's an alpha and beta blocking property within the drug. And it decreases overall peripheral vascular resistance. As we said, it prevents reflex tachycardia. Now, it is contraindicated in patients with asthma and COPD. So you want to keep them supine, measure the blood pressure at least every 2 to 3 minutes, and then stop the infusion when the blood pressure has fallen to your target level. Infectious diseases of the heart. So endocarditis, infection of the inner lining of the heart, characterized by endocardium inflammation. So what happens is you get some bacteria in the bloodstream that tends to colonize in the heart valve or other damaged tissue in the heart, and it begins to multiply. So most people that are at the most risk of this is going to be mitral or aortic valve disease patients, prosthetic heart valves, congenital heart disease. You also get right-sided endocarditis, so that can affect the tricuspid and pulmonary valve. Typically going to be IV drug users, patients with infected central venous catheters, dialysis shunts, transvenous pacing wires, but they also get an infection through the bloodstream. Endocarditis. I'm just going to kind of fly through some of these, so I'm just going to count on you guys to take your time and look over it. Severity of illness depending on the virulence of the infecting organism. So mild, you can have gradual symptoms, low-grade fever. Severe is serious illness developing over weeks with a high-grade fever. So you can see things like fever, chills, headache, loss of appetite, weight loss, all those kind of night sweats for sure. Treatment, we're talking about some supportive care. For us, really, what are we going to do? I mean, for infections, we don't do a whole lot, right? So general supportive care is going to be our big deal. But they're going to have to get some antibiotics and all of that. So, as paramedics, what we typically do is treat what we see and treat symptoms. So, we don't treat underlying diseases and all of that. So, you're going to treat them as needed, allow them to get comfortable, apply your monitor, apply pulse ox. If the patient has heart failure, which they could, follow your protocols. If possible, transport without lights and siren. In all these cases, in my opinion, we should try to transport without lights and sirens. It's just creating so much more anxiety and undue stress. But in the event that they need to get some antibiotics, and in the event they don't work, then they may end up having to get some surgery done. So what can happen if it's left untreated is the valve flap can become inverted or prolapse essentially, and then blood from the left ventricle may leak into the left atrium, so regurgitation, right, during contraction. So just faulty valve, which is not good. Pericarditis, inflammation of the pericardium that envelops the heart, so caused by viral, which is most common, can be bacterial or even fungal infections. Treatment's going to be NSAIDs or non-steroidal anti-inflammatory. So, ask the patient about recent flu-like signs and symptoms. These are going to be the kind of people that are talking about kind of the flu. Chest discomfort is the most common symptom of pericarditis. Sharp stabbing chest pain that is made worse by deep inspiration, coughing, or lying flat. So remember, we talked about positional pain. We talked about, is the pain reproducible? Does the pain, let me back up. When we are looking at cardiac versus not cardiac, so cardiac event, are we looking at an MI versus whatever? So is the pain reproducible? does it increase or decrease with deep inspiration or deep expiration? Does positioning help? So when you're listening to heart sounds, you may reveal a pericardial friction rub, but it's not always present. So how might this present to you? Pale skin, JVD, normal breath sounds, ST segment elevation, and multiple leads. So remember, I think I talked about this already. Yeah, we did. But with pericarditis, you can get what they call diffuse ST elevation. So when you see, I don't think I have it up here, no. But when you see the word diffuse, essentially we're saying there's in multiple leads. So not multiple leads meaning 2, 3, and AVF, but we're saying you see ST elevation kind of globally, kind of throughout the entire EKG. And I do remember now we talked about, more than likely they're not having an MI in every vessel all at the same time. So that should be a sign that that's probably what we're talking about is pericarditis, not an MI. Because remember, we look for reciprocal changes as well. So we're not looking for elevation in 2, 3 in AVF and 1 in AVL. We expect depression in AVL, right? Or if we have elevation in 1 in AVL, we expect depression in 2, 3 in AVF. Ooh, there's a lot of talking right there. Sorry about that. Give me a drink. All right. So supportive care, monitor O2, IV, be prepared to treat any dysrhythmias that you might have. Treatment, viral, it usually resolves on its own. Bacterial, typically treated with antibiotics. And then fungal, of course, with an antifungal. Myocarditis, inflammation of the thickest layer of the heart, the myocardium. It's usually benign and self-limiting. If untreated, though, they impair the heart's ability to pump. So what can happen then? A lot of bad stuff. Right ventricular failure, left ventricular failure, dysrhythmias, death, obviously some bad stuff. It can be caused by a lot of things, bacteria, parasites, viruses, rheumatic fever, all kinds of stuff. Exposure to chemical poisons, even radiation therapy, alcoholism can cause this. So most cases are associated with flu-like symptoms. So notice several of these have been kind of this flu-like symptom stuff. Symptoms include fatigue, decreased appetite, shortness of breath, joint and muscle ache and pain, fever, palpitations, tachycardia, tachypnea, all these things. Crackles. So you might see that low voltage QRS complexes on the ECG. So you can remember when you hear that. Essentially what we're saying is you will have small little QRSs. So if you believe something's wrong, like you just have bad leads or whatever, or even if you just want to see it better, you're always able to adjust the gain on your monitor. But this is pretty common with myocarditis, is that you're going to have low voltage QRS. Sometimes you can even get some ST segment elevation. So differential diagnoses, ACS, of course, aortic dissection, heart failure, pneumonia, and pre-hospital care is supportive. So once again, we're not going to do anything. We're not going to be a hero here, but what we're going to do is all that general supportive care, IV, monitor O2, 12 lead, all that. Rheumatic fever, inflammatory disease caused by streptococcal bacteria. So causes mitral valve stenosis, leading to heart complications. And with that, general supportive care again. So scarlet fever, sore throat, fever, rash, general supportive care for us. Aneurysm, dilation or outpouching of a blood vessel or wall of a heart chamber. So obviously that doesn't sound good. A dilation or outpouching of a blood vessel or wall of a chamber. So aneurysm, greatest concern are those that involve the aorta, such as an acute dissecting aneurysm of the aorta. The aorta is such a strong vessel anyways. You have an issue there, there's a good chance someone's not going to make it. So the pathophysiology, waves of blood pound against the aortic walls, exposing the middle layer to the blood under high pressure. Blood flows through the tear. You start to get that tear in the inner lining of the aorta, near the weakened portion of the vessel. Blood flows through the tear and between the layers, exposing the middle layer, and then blood fills the space between the layers of the vessel, causing them to separate. Aortic dissection may begin anywhere along the aorta, but most begin in the ascending aorta within 2 inches of the aortic valve or the descending thoracic aorta. Arteries lose elasticity prematurely by atherosclerosis, high blood cholesterol, hypertension. Usually caused by cystic medial degeneration. So aneurysms of the ascending thoracic aorta caused by cystic medial degeneration. Acute dissecting aneurysm of the aorta. So chief complaint, sudden chest pain. What you expect to see is that. Ascending aorta dissection, pain that is substernal or located in the neck, throat, jaw, or face. Descending aortic dissection, flank pain, pain between the shoulder blades, back, abdomen, or extremities. So the pressure of the large amount of blood on surrounding organs can produce these symptoms. So almost all patients report the abrupt onset of constant, unbearable pain. So here's comparison of MI with dissecting aortic aneurysm. You see the onset is gradual versus abrupt. The severity increases with time versus maximal from the outset. So this is just 10 of 10. Timing of pain doesn't go away once it's started. Location, back is often involved between the shoulder blades. And you may have a blood pressure discrepancy between the arms or a decrease in femoral or carotid pulse. Feeling of impending doom, weakness, numbness in extremities, signs of ischemia, heart failure. Signs and symptoms depend upon the location and the extent. One of the more vessels of the aortic arch is compromised, so pressure differences greater than 20 millimeters of mercury between the arms may indicate the presence of an aortic aneurysm. Suspect dissection if this finding is accompanied by acute neurologic changes. So they could show signs and symptoms of a stroke. And then descending aortic dissections are common in older adults. Pain is less severe than ascending or aortic dissections. Distal pulses may be hard to feel. Rupture of a thoracic aneurysm may occur, so signs of a hemothorax may be present if it occurs and ruptures into the pleural cavity. Signs of a tamponade may be present if the dissection ruptures into the pericardial cavity. So rupture of an abdominal aortic aneurysm may occur. So it'll normally be associated with sudden back pain. It'll likely be accompanied with abdominal pain and tenderness. Patient might be hypotensive, have a pulsating abdominal mass. Don't push on that. If you didn't know that, don't do that. And we are winding it down, guys. Management. They are in need of what we call diesel therapy. You need to get them to the right place at the right time and don't freak them out and stress them out. So we're going to give them adequate pain relief. May require a lot. Get you a line, of course. Apply your cardiac monitor, pulse ox, IV fluids per protocol. Opioids if the patient can tolerate. Do not delay transport. So nothing can be done to stabilize the patient's condition in the field. This patient requires aggressive therapy. So that's what they need. They don't need us. Oops, hang on. Oh, I don't have this one with me. So let's look at it. Hang on a second. Oh, my notes. All right. Last bit. So acute arterial occlusion is a sudden disruption of arterial blood flow that occurs because of a thrombus, an embolus, a tumor, direct trauma. So we're talking about acute arterial occlusion and acute limb ischemia. So thrombus blocks an artery that was narrowed, and when that does, the muscle contraction can stop the blood flow, collateral circulation develops, and then If you have an extensive amount of that, then the patient may notice no change or a mild increase in symptoms. And that collateral circulation is the body's ability to create another circulatory system, essentially. That's what happens within the heart as well, is you'll have collateral circulation. So if you start having, the body starts noticing, a blockage or whatever, it can actually start creating additional circulatory structures. So embolus, most common cause, begins in the heart and travels to the extremities. Conditions that favor origination in the heart. A lot of different things here. We're going to zip through this, guys. Direct trauma to an artery can be caused by an extremity injury, dissecting aneurysm. Results when an arterial occlusion suddenly reduces blood flow to an arm or leg. So you get some pain, some cramping, disappears after a brief rest. If symptoms began suddenly, the probable cause is embolus. If it occurred gradually, it's probably a thrombus. So the 5 P's, you've seen this before, I'm sure. Pain, pulselessness, pallor, paresthesia, and paralysis. So those are the things how we start to look at limb and like compression things and all of that. If limb ischemia affects a lower extremity, sit the patient up with the feet lower than the chest. Establish an IV line. Once again, we're just going to be doing essentially general supportive care. Keep the ambulance warm to avoid vasoconstriction to the skin. 5 P's. Now, thrombosis, acute deep vein thrombosis, so DVT. Thrombophlebitis, the development of a blood clot in an inflamed or damaged vein. So, depending upon whether it's superficial or not, superficial thrombophlebitis, when a clot develops on the skin surface, or if it develops in the deep veins of the extremity. So, 3 important factors that predispose a person to develop this thrombus: sluggish blood flow, damage to the inner lining of the vessel, or blood clotting disorders. Patient may seek care because of swelling, pain, or tenderness. You can get, redness and start having some issues with pain as well. Compare the extremities in pairs. Whenever we're looking at upper and lower, look for signs of inflammation, pain on dorsiflexion of the foot. Do not rub or massage the limbs. Might end up just knocking that sucker loose, and off it goes, on to the races. Once again, general supportive care, right? We're going to just treat what we see. Transport them without lights and sirens if you're able to. And there we go. Holy moly. You guys didn't think we were going to do it, did you? I thought I was going to drag this out for a whole nother one. So that is that, chapter 17. Once I didn't mention it, but I apologize there. Somehow I thought I had sent out all of the assignments. I realized the other day that I created them all, but I had not hit the give button. So you still had a whole week to get them all done. So if there's something you guys like or don't like about Dr. Brave's case study, I know that I put just answer the questions and send that in to me, and basically all the questions are answered. I just want to make sure that you're listening to that, and maybe there's something that you would want to know about it or whatever. So once you respond to me and tell me that you respond to the thing as written, you're going to get full credit for it. I just want to make sure that we're using it. That's a valued resource. Okay, that's it. You guys be good, and I guess we'll see you for ACLS, right? Wednesday, Friday. As I've said in the past, labs are always open. You guys, I really encourage you to spend some time in the lab. If nothing else, get together with classmates away from here. Meet at somebody's ambulance service or wherever. But for you guys that aren't don't have a lot of experience at this stuff, it's going to be harder, and you're going to need more time. So I really encourage you to do what you can. Wednesdays and Fridays, this week and next week are going to be labs. And, next week's going to be CLS, so this week. So you guys be good. And I'm just kind of rambling, so signing out.